Today we'll discuss about surgical endodontics. So, endodontic surgery is the removal of the tissues other than the contents of the root canal to retain a tooth with the pulpal or the periapical involvement. See, what is the rationale behind it? So, why do we do this? It is nothing but it is to remove the diseased tissue present in the canal and around the apex and retrofill the root canal space with the biologically inert material so as to achieve a fluid tight seal. So if you see, the objectives of the endodontic surgery is to remove the diseased periapical tissue such as the granuloma, cyst or the overfilled material, or the root inspection for knowing the etiology of the endodontic failure, fracture or the accessory canals, and also to provide the fluid tight seal at the apical end by the retrograde preparation and the obturation, and also to eliminate the apical ramifications by root resection so as to remove the cause of the failure for endodontic treatment. These are the main objectives for the endodontic surgery. If you see, the indications for endodontic surgery is that first we have to check for the need for surgical drainage, especially in case of the sinus tract openings, and also in case of the failed non-surgical treatment such as irretrievable root canal filling material or irretrievable intraradicular post, and also in the calcific metamorphosis of the pulp space, and in case of the procedural errors such as the instrument separation or the root perforation, and in anatomical variations such as the root dilacerations and apical root fenestrations or non-negotiable root curvatures, and in corrective surgery such as the root caries or the root resection or the root resorption, and replacement surgeries such as the intentional replantation or the post-traumatic replantation, and also in case of the endodontic implants. If you see, the contraindications for endodontic surgery includes we have first and foremost we have to check the periodontal health of the tooth. That is, the tooth mobility and the periodontal pockets are the two main factors affecting the treatment plan. And also we should check the patient health conditions such as uncontrolled diabetes and uncontrolled hypertension with the uncontrolled bleeding disorder or immunocompromised patients are contraindicated for endodontic surgery. And also the short root length in which the removal of the root apex further compromises the prognosis, and also the proximity to the nasal floor or the maxillary sinus has to be avoided in it may lead to the surgical perforations to the sinus. So these are the indications and contraindications of the endodontic surgery. And if you see, the classification of endodontic cases according to the Rubinstein and the Kim, the assessment of the root form and the associated integrated implant treatment outcome, they are classified into Class A to Class F. The Class A is the absence of the periradicular lesion but persistent symptoms after non-surgical treatments, whereas Class B is the presence of periapical lesions and no periodontal pockets, whereas Class C is the presence of large periapical lesion progressing coronally but no periodontal pockets, and Class D is any of Class B and C with a periodontal pocket, whereas Class E is the periapical lesion with endodontic and periodontal communication with no root fracture, whereas Class F is the tooth with periapical lesion and complete denudation of the buccal plate. And if you see, the pre-surgical considerations, before initiating the surgical procedure, the clinician should follow few factors which may affect the treatment outcome. So first and foremost, we should know about the success of the surgical treatment versus the non-success, and review of the medical history of the patient and the consultation of the physician if required, and also the patient motivation and also the aesthetic considerations like scarring. And the evaluation of the anatomical factors with the periodontal evaluation and the pre-surgical preparation, taking an informed consent, play a key role in surgical treatments. Coming to the first and foremost, incision and drainage. In case of the intraoral and the localized swelling, the only incision and drainage are considered. So, the surgical drainage is indicated in case of the hemorrhage or the purulent exudates from the soft tissue. In such cases, you have to give an anesthesia and give the incision in the most dependent part of the swelling with a scalpel and place the horizontal incision at a dependent base of the fluctuant area for effective drainage to occur. And that's how the drainage is done in case of the incision and drainage. And if you see the periradicular surgery, first and foremost, the local anesthesia and hemostasis has to be acquired. So for that, lidocaine with adrenaline is the local anesthesia of choice to obtain the profound anesthesia and optimal hemostasis. So after this, we can go for the flap designs and the incisions. First and foremost, the principles and the guidelines for the flap designs is to avoid the horizontal and severely angled vertical incisions, because the gingival supply occurs from the supraperiosteal vessels, and these follow vertical course parallel to the long axis of the teeth. And the collagen fibers of the gingiva and the alar mucus forms the attachment for the crestal bone and the supracrustal cementum to the gingiva and the periosteum of the radicular bone. And also avoid the incisions over the radicular eminences. And the incision should be placed such that the flap is repositioned over the solid bone. And the base of the flap should be more than the free margin to preserve an adequate blood supply. Incisions should never be placed over the area of the periodontal bone loss or the periradicular lesions. And the extent of the vertical incision should be sufficient to allow the tissue retraction to seat on solid bone, thereby leaving the root apex well exposed. And the extent of the horizontal incision should be adequate to provide the visual or the operative access with a minimal soft tissue trauma. And also avoid the incisions on the mucogingival junctions. If you see the functions of a flap, raise the soft tissue to give the best possible view and exposure to the surgical site, and to provide the healthy tissue that will cover the area of the surgery, decreasing the pain by eliminating the bone exposure in obtaining the optimal healing. And if you see what are the classification related to the mucoperiosteal flaps, that is the full mucoperiosteal flap, which includes the triangular single vertical releasing incision, rectangular double vertical releasing incision, trapezoidal broad-based rectangular, horizontal with no vertical releasing incisions. And also the limited mucoperiosteal flaps include the submarginal curved, that is semilunar, and the submarginal scalloped rectangular, that is Lübke-Oschenbein flap. Coming to the triangular flap, according to the Fisher, it is a full thickness, mostly used in case of the endodontic surgeries. It is usually given in case of the maxillary incisors and the maxillary and mandibular posteriors, but it is only recommended flap design for the posterior mandible region. And it is not indicated in the canine region because of its long teeth. Here, if you see, the advantage is that it has a rapid wound healing and ease of wound closure, but it has limited surgical access. Now we'll see the rectangular flap. It is an extension of the triangular flap. Here, the two vertical releasing incisions and the horizontal intracircular incision is given. and it is indicated in case of the mandibular anteriors, maxillary canines, and the multiple teeth. So, it is not recommended in case of the mandibular posterior teeth. If you go back, the triangular flap is more indicated in case of the mandibular posterior teeth. Here the advantage is that it has enhanced surgical access and easier apical orientation with excellent wound healing potential. But the disadvantage is the wound closure has the flap reapproximation and the post-surgical stabilization are more difficult than the triangular flap. Coming to the trapezoidal flap. It was described by the Newman and Iken. It is formed by the two releasing incisions which join a horizontal intracellular incision at the obtuse angles. Here, one of the disadvantages of this trapezoidal flap is that wound healing by secondary intention may occur and the pocketing or clefting of the soft tissue, which may result in the compromise in the blood supply. So, this is not very indicated in the periradicular surgery. And if you see the envelope flap, it is formed by the single horizontal intracellular incision and usually recommended for corrective endodontic surgeries. It is useful for the perforation defects cases and root resection with also the hemisection. If you see the limited mucoperiosteal flap, it is a semilunar flap and it is formed by the single curved incision. It is semilunar because of its horizontal incision is modified to a depth towards the incisal aspect in the center of the flap, giving the resemblance of the half moon. It is fast and easy to reflect with no involvement of the marginal and interdental gingiva, but it has limited surgical access. Now we'll see Ocean-Ben-Lübke flap or the submarginal scalloped rectangular flap. And this flap was developed by an endodontist and a periodontist, and it is the modification of the rectangular flap. In this, the scalloped horizontal incisions is given in the attached gingival, which forms two vertical incisions made on each side of the surgical site. That's what we can appreciate in the picture. And this is indicated mostly in the presence of the gingivitis or the periodontitis associated with the fixed processes or where there is a bony descent is suspected. And if you see, the most advantageous with this flap is that it does not involve the marginal and the interdental gingiva, and there are unaltered soft tissue attachment levels. And here we can see the crestal bone is also not exposed and there is an adequate surgical access also, which also gives us the good wound healing potential when compared to the semilunar flap. But this flap also has some disadvantages, such as there would be a disruption of blood supply to the unflapped tissues and there may be the flap shrinkage, and sometimes it is difficult to reapproximate and wound closure with this flap. Okay, now we'll see the flap design considerations in the palatal surgeries. Usually, these are indicated in surgical procedures for palatal roots of the maxillary molars and premolars for retrofilling, perforation repair, or the root amputation. And also in cases of the perforation or resorption repair of the palatal surface of the anterior teeth. And there are two type designs. One is the triangular, another is the horizontal. In triangular flap, what happens is that the vertical releasing incision extends from the marginal gingiva mesial to the first premolar to the point near the palatal midline and is joined by the horizontal intracellular incision which extends distally as far as to provide access. And the relaxant incisions are given between the premolar and the canine to decrease the chances of severance of the blood vessels. That's how the palatal incisions are made. Now we'll see how this flap reflection and the retraction happens. See, the reflection of a flap is a process of separating the soft tissues from the surface of the alveolar bone. and it should always begin in the vertical incision a few millimeters apical to the junction of the horizontal and the vertical incisions. Okay, and this elevation should be continued until the attached gingiva is lifted from the underlying bone to the full extent of the horizontal incision. And the retraction of the tissues provides the access to the periradicular area. For this, retractor should rest on the cortical bone with a light but firm pressure directed against the bone. Okay, and after retraction, we go for the hard tissue management. So, here the root apices are approached by making an access through the cortical plates. In case the radiolucency is present around the root apex, the osseous tissue need not to be removed surgically. But when the radiolucency is not present periapically, osseous cutting is required to gain access to the root apex. And for that, we have to maintain the speed of cutting and the coolant use, and you should be maintaining the types of burr used for the cutting also. And after cutting the tissue, and you can go for the root end resection. So here what happens is that we remove the we just resect the tooth and its removal together with the pathological periapical tissues. And what all to be considered while before the root end resection is that the instrumentation and the extent of the resection and the angle of the root end resection. Here, the high-speed handpiece with a surgical length fissure is preferred because the round may result in the gorging of the root surface. And according to the Cohen, the length of the root tip resected depends on the frequency of the lateral and apical ramifications at the root end. And this is the most important feature of the endodontic surgery. And it was found that when the apical 3 mm is resected, the lateral canals are reduced by 93% and ramifications are up to 98%. So the extent of resection is very important factor in the endodontic surgery. And if you see the angle of the root end resection, earlier it was thought that the root end resection at 30 to 45 from the long axis of the root facing the buccal or facially provides an improved accessibility and visibility of the resected root end. But few studies have shown that the beveling of the root end results in the opening of these dentinal tubules on the resected surface area, so which communicates with the root canal space, causing the apical leakage even after the retrofilling is done. So a bevel of 0 to 10 degrees is recommended for resection because it allows the inclusion of the lingual anatomy with less reduction, and if multiple canals are present, increase in the bevel causes the increase in the distance between them. So with the short bevel, it is easier to keep the instruments within the long axis of the tooth than the long bevel. And whereas the long bevel will expose the more dentinal tubules, resulting in the micro leakage over a period of time. That's how it is done. And coming to the after the resection, we are going for the root and cavity preparation. In that, we have the traditional root and cavity preparation, other one is the ultrasonic root and preparation. So, for traditional, we use the miniature contra angle or the straight handpiece with a small round or the inverted cone burr to prepare the class 1 cavity, which only confines to the root canal. Though these preparations seem to be placed along the long axis of the tooth, but they are directed parallelly and palatally, which may cause perforations. So you have to be careful while using this. Whereas the ultrasonic was developed to resolve the main shortfalls of the burr preparation, and these are specially designed ultrasonic root and preparations of the instruments, which result in the smaller preparation size with a minimal bevel, and the parallel walls for better retention and less debris, and the smear layer than the prepared with the burr. So, the retrograde cavity preparation using the ultrasonic handpiece is done. Later on, the placement of the restorative material is done with the handpiece and also with the carrier, which helps in placing the restorative material, and with that we can remove the excess material from the cavity. After that, we go for the final inspection of the root and filling, and cleaning of the surgical site is done, and the radiograph is taken to assess the presence of any root fragments or there is any surplus root and filling material. Later on, after checking all this, the flap is replaced in the original position with the incision lines approximated as close as possible. Now the flap is compacted by applying the light yet firm pressure for 2 to 5 minutes with the help of the damp surgical gauze. And this compression helps in approximation of the wound edges and their initial adhesion. So this is about the endodontic surgery. So now we go for the other method of surgical procedure known as the replantation. The intentional replantation is nothing but the act of deliberately removing the tooth and following the examination, diagnosis and endodontic manipulation and repair and returning the tooth to its original socket. So here what we does is that we have to extract the tooth with a minimal trauma to the tooth and socket and incise the periodontal fibers using the number 15 scalpel bar and gently elevate the tooth using the forceps in a rocking motion until the grade 1 mobility is achieved. And the forceps should be placed away from the cementum so as to avoid any damage to the periodontal ligament. And keep the root surface moist by wrapping it in a gauze soaked in the physiological saline such as HBSs. And there should be a thorough examination of the roots for defects or the fractures and repair of the defects. If suppose there is any repair or procedure should be done quickly in the bath of the normal saline or HBS cells has to prevent the desiccation. And irrigate the extraction socket using the normal saline and gently place the tooth back into the socket and place the roll to gauge piece on the occlusal surface. And ask the patient to bite it for at least 5 to 10 minutes. This helps in seating the tooth in the socket. Now, stabilize the tooth with the periopack sutures and splints and recall after 7 to 14 days to remove the stabilization and evaluate the mobility. Here, the prognosis depends upon the preventing the trauma to the PDL and the cementum during extraction and minimizing the extraoral time. And this is indicated in case of the accidental avulsion or perforation in the inaccessible areas or calcifications or the post or the separated instrument present in the canal of the non-surgical endodontic therapy is difficult. Now we'll see another procedure known as the hemisection, root resection or the root amputation. Here, it is the removal of unrestorable root which may be affected by the periodontal, structural and the caries. And hemisection is independent of the bicuspidization. Here, it includes the splitting of the tooth and extraction of one half, following by the bridge, whereas the bicuspidization involves the retaining of both the split sections of the tooth and then restoring them with the crowns. So that's how it is done. If you see the endodontic implants, these are used for providing the stabilization of the teeth in which the alveolar support is lost due to the endodontic and the periodontal disease, which also helps in enhancing the root anchorage by extension of the artificial material beyond the alveolar socket but within the range of the alveolar bone. So that's how these endodontic implants are placed. So after all the surgical procedure, the post-surgical care is must. So it includes providing the genuine expression of the concern and reassurance to the patient and a good patient communication regarding the expected and then normal post-surgical sequelae as well as the detailed home care instructions. So the success of the surgical endodontics varies between 30 to 80%. So this is about the surgical endodontics.